So good morning. My name is Soo. I'm one of the ID pharmacists here at Tampa, VA. And today we're going to get to the heart of the HIV drug interactions. And before I proceed, I want to let you know that I have no financial or personal relationship with any of the commercial entities, and the views expressed in this presentation don't necessarily reflect the views of the VA. And just a quick disclaimer is the listed interactions are not all inclusive, and the VHA antiretroviral formulary will be primarily used for reference throughout the presentation. So by the end of the presentation, you should be able to describe different mechanisms of drug-drug interactions and identify drug interactions by the antiretroviral therapy or ART components. And lastly, be able to construct plans to prevent and to mitigate drug interactions with ARTs. So why is drug interactions important, especially in HIV patients? And the reason is because HIV patients, they have been having increased life expectancies due to the effective ART regimens that are easily available in the market. So pretty much these are the HIV patients with advanced age. They get routinely prescribed for multiple medications to manage other chronic states. So what that means is they will end up with co-administration of multiple medications, meaning increased risk for serious drug interactions. So in fact, up to 40% of all HIV patients have at least one drug interaction involving with their ART regimen. So to understand the drug interaction, you have to understand the two phases of drug action. So under the pharmacokinetics property, there are three components. So absorption, metabolism, and excretion of drug. And these three cores are the ones that gets impacted by drug interactions. So when these the absorption, metabolism, and excretions are changed down the stream, they will change the pharmacodynamic property of a medication. So those include the onset, peak, and duration of action of medications. And the consequence of drug interactions when they are not managed appropriately will lead to it can lead to a decreased drug action, which leads to HIV resistance and treatment failure. But on the other hand, it can also cause an increased drug action, which whether that's an HIV medication or other interacting medications, and that leads to drug toxicities and side effects, which then will lead to poor tolerance by the patient side. So today we're going to go over different mechanisms of drug interactions first. So the first is the drug absorptions, which happens due to the interaction at the site of absorption. So this can be either chelation or change in the pH or change in the gastric acidity, which both lead to change in drug absorption. So let's talk about the chelation first. So the word chelate means claws or arms of animal in Greek. So what that means is it's a formulation of a strong covalent bond between organic molecules, or in this case drugs, and other metallic cations. So some of the common ones that we encounter are calcium, copper, magnesium, iron, and aluminum. So when these metacations bind to the medication, it changes the degree of ionization, which then leads to reduced permeability through the GI tract, and also increase the systemic elimination of the drug. So a perfect example of chelation is actually using activated charcoal for patients with chemical poisoning, since the activated charcoal will bind to the poison and reduce the GI absorption and also increase the systemic elimination. And on the other side of the drug absorptions, about the altered pH. So our gastric acidity under normal condition is pH of 1.4. And then under these conditions, medications, it will impact the proportion of unionized versus ionized state if the gastric acidity changes. So medications that are considered as weak acid, they remain as unionized under acidic environment and have a increased gastric permeability. And in contrast, the medication considered as weak base, they remain ionized under acidic conditions and therefore have a reduced gastric permeability. So we have to be mindful when patients are taking medications that changes the gastric pH. So some of the common ones include the protein pump inhibitors or PPIs, H2RAs, and antacids, because all of those three will increase the gastric or will decrease the gastric acidity by increasing the pH. So we have our first question of the day. So which of the following are associated with reduced systemic absorption through chelation? So we have a ferrous sulfate, omeprazole, calcium carbonate, and famotidine. So let's take about 15 seconds to answer this. 15 to 30 seconds.
Not more than that.
It can be more than one if you think there are more than one answer.
C.
So I hear C. Is there anything else, or is C the only one?
It's not due to metal, due to the
All right, so I hear A. Well, A isn't like one only. All right, so, well, the answer is C. So, ferrous sulfate has iron, and calcium carbonate has calcium. So both have the metal cations that will bind to a medication and can cause reduced gastric absorption. And the next is drug metabolism, which is a chemical modification of drugs into an active, inactive, or toxic metabolites. So medications that are considered as a prodrug will be converted to an active metabolite through the metabolism, versus the ones that are already in an active form will then go to an inactive metabolite and get ready for systemic elimination. So there are three phases of drug metabolism. So phase one is modification from an inactive to an active drug, versus phase 2 and 3 is involved with conjugation and conversion to a water-soluble molecule to get ready for elimination. So there are multiple enzymes involved in drug metabolism, including the P-glycoprotein, we refer to as PGP, and then cytochrome P450. I commonly refer to it as CYP450 enzymes. But it's the CYP450 that causes, that is the biggest workforce for phase 1 to phase 3 of drug metabolism. So CYP450 enzymes is actually a family of heme-containing isoenzymes. So there's like 1A, 2A, 2D, 3A, etc. But it's the 1A2, 2C family, 2D6, and 3A4 that are with the most significance in terms of drug metabolism. And each of these isoenzymes have a very different substrates that they work on, as well as inducers and inhibitors that changes the metabolism, the function of metabolism of these isoenzymes. So when a CYP450 enzyme is induced, its activity is the metabolizing activity is going up. So what that means is drugs that are remaining as a prodrug will then become will be changed to an active metabolite, therefore have an increased toxicities. Versus medications that are already in active drugs will then be converted to a water-soluble molecules, therefore they will be excreted outside of the body and causes a therapeutic failure risk. And on the other hand, when the CYP450 enzymes are inhibited, the prodrugs will not get converted to an active drug, therefore they will not be producing therapeutic effect, which leads to therapeutic failure risk, versus the active medications or active drugs will remain as active and will not be getting eliminated. So what that means is the medication will continuously produce therapeutic effect, which can cause increased toxicities. And like I said, each isoenzymes have a different inducers and inhibitors. So I kind of included the more significant ones here for your reference. So in terms of the inducers, what kind of medications do you guys see in common here? Yeah, rifamycin is a big one. Yeah, so anticonvulsants, right? So they are known as the biggest, isoenzyme inducers on top of the rifamycins. And when we look at under isoenzyme 3A4, we also see certain HIV medications, including the efavirenz, etravirenz, and nevirapine, as significant metabolizing inducers as well. And we also see St. John's wort, which is a commonly available over-the-counter medication regimen that heavily induces 3A4 metabolism. Versus on the inhibitor side, they are slightly different, but we see amiodarone and other cardiac medications. We also see ciprofloxacin and also ritonavir, which is commonly used along with protease inhibitors for HIV treatment. And we also see Bactrim and cabisistat and atazanavir. So there are a lot of medications that will function as an inhibitor, whether that's a non-HIV medication related, or the HIV medications itself can function as an inhibitor of CYP450 enzymes. So for the CYP450 inducers, they will increase the metabolic pathway by 50 to 80% for the ones that are considered as a moderate inducers, versus for the ones that are strong inducers will increase the metabolic pathway by more than 80%. Versus on the other hand, for the inhibitors, they will decrease the metabolic pathway by 2 to 5 folds if they're moderate inhibitor, versus strong inhibitors will cause reduced metabolism by more than 5 folds. So our next question is, which of the following drug class or drug classes will increase the risk of CYP450 induction? So we got the ART boosters, anticonvulsants, antiarrhythmic agents such as amiodarone, and rifamycins such as rifampin. So I hear D. D, the only one? B and D. Okay, yeah, so looks like everyone's on the track. So anticonvulsants is the biggest known inducers, and also rifamycin as well. Versus the ART boosters, so cabisistat, ritonavir, and certain antiarrhythmic agents they are known as an inhibitor, not an inducer. So we talked about drug absorptions and drug metabolism. And the next part and the last part is a drug excretion. So there are multiple drug excretion process. The first is biliary excretion, but this is more so limited to lipophilic medications with a large molecular weight. But in terms of the from a pharmacist standpoint, we actually focus more on the renal excretion. So this, because it accounts most of the drug elimination process, and this is an active tubular secretion in the proximal tubule through the organoanion transporter. And the renal excretion itself the whole process is an energy dependent process, and it can be blocked by a competitive inhibition to the OAT. So there are multiple medications that are known as a significant OAT enzyme inhibitors, including the dolutegravir, which is part of the HIV regimen, and also probenecid. So what that causes is they will bind to the OAT enzyme, therefore inhibiting the OAT substrates in the bloodstream. Will prevent these substrates from moving from the bloodstream to the proximal tubule, therefore inhibiting their renal excretion. And versus there are other medications that can induce the OAT process. So rifamycin is a very common one, therefore they will increase the renal excretion process. So we talked about drug metabolism, drug absorptions, and drug eliminations. And now let's try to apply that to each component of ART regimens. So we'll start from INSTIs, move on to nucleoside reverse transcriptase inhibitor and non-NRTIs, PIs, and certain miscellaneous regimens. So first, for the INSTI absorptions. So they will have, so the chelation is the biggest issues with the INSTI absorption. So a lot of times these metal cations will bind to the INSTIs and cause reduced INSTI absorption by 30 to up to 70%. So meaning that will lead to a reduced INSTI efficacies with increased risk of HIV treatment failure. And the extent of chelation really differs among the INSTIs itself and the type of cations that we are talking about due to their molecular size. And by the way, I want to highlight here that these absorption issues with INSTIs do not apply to the injectable INSTIs. So a common example is the cabotegravir IM injection that we use for Cabenuva for HIV treatment and Aptitude for HIV PrEP regimen. But for bictegravir, for patients taking aluminum, magnesium, and irons, they need to be appropriately spaced out by taking these supplements at least 2 hours after or 6 hours before taking their bictegravir. But for calcium, due to their smaller molecular weight, it can be administered together with bictegravir with food simultaneously. Versus for the cabotegravir and dolutegravir and elbigravir, so for all of these three INSTIs, if the patient is taking metal cation, they need to be administered at least 2 hours before or 6 hours after. But the biggest exception is the raltegravir. So for aluminum, magnesium, and ferrous sulfate, they should be avoided to be used with raltegravir. Versus for patients taking calcium, you can still administer with raltegravir if the patient is taking 400 BID, but patients taking high dose raltegravir, such as 1200 milligram Q daily, it is recommended to avoid using with calcium. So the bottom line, or the bottom line is to separate INSTIs by at least 2 to 6 hours, or have them take simultaneously with food for the calcium. And the INSTIs are also susceptible to drug interactions through metabolisms. So they can have a reduced INSTI serum concentration by 40 to 80% if their metabolism is altered. And the extent of the interaction really varies depending on the type of the inducer we're talking about and the CYP450 specificity of the INSTIs. So for rifampin, it has the most drug-inducing capacity, versus the rifapentin has the least CYP450 induction capacity. And in terms of the CYP450 substrate specificity, raltegravir has the least specificity compared to all other INSTIs. But for rifamycins, generally they're contraindicated to be used with INSTIs, but there's an exception to the raltegravir again. So for patients taking rifampin, you can increase their raltegravir dosing by 800 milligrams twice a day. Versus patient taking rifapentin, you can still use raltegravir as long as you increase their dose to 400 BID dosing. Again, rifamycin is not the only significant inducers. So we also have anticonvulsants. Unfortunately, due to their potent inductions, anticonvulsants are not recommended to be used with any type of INSTIs. So the general rule of thumb is INSTIs are mostly contraindicated with strong CYP450 inducers, and you should really consider using an increased INSTI dosing frequency if the drug interaction is completely unavoidable if you are using raltegravir. And the next is the elimination. So we talked about how certain medications or dolutegravir can actually serve as the OAT inhibitor. So, and the metformin is a big OAT substrate. So, meaning patients taking metformin with dolutegravir, they will experience increased metformin serum concentration by 60 to 80% when they take it with dolutegravir. And that can lead to increased risk of metformin-related adverse reactions, which includes GI effects, vitamin B12 deficiency, and the biggest is lactic acidosis. So there are multiple mitigation strategies are available. But for patients already taking dolutegravir that are newly starting metformin, you will have to start their metformin at the lowest dose and titrate slowly up based on their glycemic control. And make sure to closely monitor for any signs of metformin-related side effects. But the biggest part is limiting their total daily dose of metformin to 1,000 milligrams per day during the initial titration phase. Versus for patients already taking metformin and you're now about to either start them on dolutegravir or stopping their dolutegravir, make sure to closely monitor for the glycemic controls, and metformin dose adjustment may be necessary. So if you're stopping or if you're starting dolutegravir, make sure to limit their metformin to 1,000 milligrams per day during the initial phase, versus decrease their metformin dose if you are stopping the dolutegravir.
Question for you on
Yes.
For metformin, do you have a upper limit of a dose that you would use in somebody once you're through the titration phase? Lexicomp makes a point of saying max daily dose 500, which is, I don't think, very helpful.
Right.
I put a lot of patients as high as 1,000, but
Mm-hmm.
I don't really go past 1,000. I'm wondering if.
I would say the threshold is more so during the initial titration phase, and as long as you're confident that patient is tolerating it, the max dose it follows the traditional max dose for the metformin. So our next question is, we have Mr. YZ, who is a 43 years old male with a new diagnosis of HIV, and you are about to start him on Biktarvy, which has a bictegravir, emtricitabine, and tenofovir alafenamide, or TAF. And which of the following is the most appropriate counseling points that you want to provide about his Biktarvy based on other medications he is taking? So he's taking lisinopril, amlodipine, metformin, and calcium carbonate. And there's only one answer.
Attention. Fire alarm testing.
So I hear B and C.
Between 8:30 a.m. and 4 o'clock p.m. Please disregard all alarms.
So B is the correct answer. So
Once again, fire alarm testing.
yeah, he's already on metformin. So that's why C is not a. Yeah. So here, whenever I see patients on an INSTI with any type of metal cations, the first thing I always think about is the chelation issues. And I always make sure to have them take their HIV regimen appropriately, either to space them out from their cations or have them taken with food simultaneously if it is calcium. Okay, so let's move on to the nucleoside reverse transcriptase inhibitors. I'll say, NRTIs has the least drug interactions in all ART components. Pretty much it only is susceptible to metabolism and elimination. And the one that I only want to highlight to you is pretty much the tenofovir components. So there's the tenofovir alafenamide, or TAF, which is susceptible to PGP metabolism and OAT elimination. So their PGP metabolism is going to be induced by the anticonvulsants, versus the OAT elimination is going to be induced by the rifamycins. So if you have a patient who is who's already taking either rifamycins or anticonvulsants, you should avoid using TAF components. And one of a mitigation strategy is actually using a tenofovir diproxyl fumarate, or TDF component. But TDF has its own issues since it is susceptible to a 3A4 metabolism. And so one of a common 3A4 inhibitor is an NSAIDs. So when you're using TDF with NSAIDs, there will be an increased risk of TDF-associated nephrotoxicity if the co-administration with NSAIDs is for a long period of time. So if you have a patient who's taking NSAIDs with TDF and TDF is completely necessary, then make sure to closely monitor for their renal functions, especially in patients who already have a pre-existing conditions such as renal dysfunction, low body weight, or those who will be taking prolonged NSAIDs. So the bottom line here is to make sure to use TDF components in patients using anticonvulsants or rifamycins, and consider using TAF components if you have a patient who is at high risk of renal dysfunction. Therefore, TDF components should be is completely to be avoided. So we are going to move on to the non-nucleoside transcriptase inhibitors. So it gets a little bit tricky because it really depends on what type of component we are talking about within the non-NRTI components. For the rilpivirine, which requires an acidic environment, you have to be careful for the patients taking gastric pH altering regimens. So for patients taking antacids or H2RAs, a common example is the famotidine. Make sure to space them out appropriately with the antacids and their rilpivirine. However, for patients taking PPIs, which has a way longer duration of activity compared to antacids and H2RAs, it is contraindicated to be used with rilpivirine since it will decrease the rilpivirine GI absorption. So my question here is, does that apply? So for those of you who prescribe Cabenuva, does this apply to the Cabenuva injection or no? No.
No.
Oh, it does not. It does not apply to the rilpivirine injections since all of these absorption issues is within the GI tract. So if you're injecting them, it doesn't matter. But for the efavirenz, etravirine, and nevirapine, we already talked about how they serve as a 3A4 inducer. So these ART medication is going to cause reduced efficacy of other medications. So a common example is the alpha-1 receptor antagonist. So a lot of patients, especially within the veteran populations, they will be either on alfazocin, doxazocin, or terazosin. However, in this case, you should be consider using a different ART or have them switch to a different alpha antagonist therapy. Versus for tamsulosin, you can actually increase their tamsulosin daily dose up to 0.8 milligram per day if they don't respond appropriately with a 0.4 milligram per day. And we also see patients on atovaquone times, especially for HIV patients due to opportunistic infection prophylaxis or treatment. But these NRTIs can reduce the atovaquone efficacy. So try to use a different opportunistic infection regimen or different ART if possible. But for some reason, if atovaquone is the only one available for the patient due to the G6PD deficiency status or previous allergies, then make sure to closely monitor for the therapeutic effectiveness of the atovaquone while the co-administration continues. And a lot of veteran populations are also on one or even multiple antidepressants, which can be affected by the non-NRTIs. So they include the bupropion, citalopram, sertraline, and trazodone. So make sure to get them monitor therapeutic effectiveness of their antidepressants while you continue the co-administration. But there's one more thing. So the rilpivirine and all other NRTIs, they also serve as a substrate of certain 450 enzymes. So what that means is these antiretroviral therapy effectiveness will be impacted by certain other medications. So a common one is a dexamethasone, which serves as a strong 3A4 inducer. So dexamethasone will significantly decrease the rilpivirine serum concentration. So it is really definitely contraindicated to be used if your patient is taking dexamethasone for more than just a single dose. Versus for efavirenz, etravirenz, and nevirapine, make sure to closely monitor for their virologic response while the co-administration continues, if the co-administration is completely necessary. Versus anticonvulsants and rifamycins, and I think I made it very clear that they are very strong inducers at this moment. So generally they are contraindicated to be used with any type of NNRTIs. We have our next question. So what is the most appropriate counseling points in patients starting a DEF-C, which has a emtricitabine, rilpivirine, and TAF component based on the list of other medications. So he's taking naproxen, famotidine, tamsulosin, and dexamethasone single dose prior to chemotherapy. Who thinks A is correct? C? C for correct. Okay, yes. C for correct. So make sure, since famotidine will impact their gastric pH, make sure to have them appropriately spaced out from their DEF-C due to the rilpivirine component. Why is D not correct?
Oh, 12 hours.
I thought it was 4 hours.
It was 4 hours before and 12 hours after, because famotidine effect lasts for 12 hours.
No, it's 12 hours before and 4 hours after.
Oh.
It is very confusing. Yes.
I love how validating he is. It is confusing.
I'm going to admit, yeah, it is confusing. There's nothing I can do about it.
Well, and then trying to explain it to patients, if it's confusing to us, it's very confusing.
Yeah.
Some of these patients are on like 15 medications, and you're like,
Yeah.
how do you get around it?
So generally what I do is I actually, whenever, a provider places an, order, I try to specify, how to take it on the instructions. So, spaced out by at least this amount from your famotidine or etc. But going back to the answer choice D, it is correct. Well, it is incorrect since, the dexamethasone interaction with the rilpivirine only applies when it's more than just a single dose. So we're going to move on to the protease inhibitor, which is the most fun part, since it is very complicated. If you thought the famotidine thing was complicated, yeah, hang on tight. So for protease inhibitors, they are susceptible to absorption issues, especially for the atazanavir, since it requires an acidic environment for GI absorption, somewhat similar to the rilpivirine. So for patients taking antacids or H2RAs, make sure to get them spaced out appropriately, slightly different from the rilpivirine spacing. But the bottom line is for PPIs, due to their extended duration of action, it is not recommended to be used with atazanavir. So going into the protease inhibitors metabolism issues, so all protease inhibitors are to be administered with a booster, but all protease inhibitors themselves are 3A4 substrates, versus all boosters are potent 2D6 and 3A4 inhibitors. So what that means is patients taking 3A4 inducer or other medications that induce 3A4 metabolism, they are going to decrease the protease inhibitor's serum concentration, meaning it will lead to a reduced ART efficacy. Versus patients taking 2D6 or 3A substrate medications, those medication serum concentration will be significantly increased due to the booster's 3A4 inhibition effect. So bottom line here is, protease inhibitors, they are super susceptible to multiple drug interactions. So for medications that are considered as a potent 3A4 inducers, so anticonvulsants, rifamycins, and certain NNRTIs, including the efavirenz, etravirenz, and nevirapine, and also the St. John's wort, they are all contraindicated to be used with Protease due to the reduced efficacy. And in fact, they will also counteract against the booster effect, since the boosters are the inhibitors, while these medications will induce the metabolism. So for the 2D6 and 3A4 substrates that will be affected by the protease inhibitors and the boosters, so we have the statins that are, a lot of veterans are taking a lot of statins. So for atorvastatin and rosuvastatin, there's a certain dose threshold versus the simvastatin and lovastatin. They are strictly contraindicated to be used with all type of protease inhibitors. And for alpha receptor antagonists, pretty much the alphazocin and silodosin, they are contraindicated. While the tamsulosin, you can still co-administer if it is absolutely warranted, and if their benefit outweighs the risk of tamsulosin-associated toxicity, including hypertension and falling. Or you can simply switch to doxazocin at the lowest dose possible. And for the PDE5 inhibitors, for sildenafil, there's a certain dose threshold or dose limit if you're using for erectile dysfunction. But if they're taking it for pulmonary arterial hypertension, it is strictly contraindicated to be used with protease inhibitors. Versus for tadalafil, there's a different dose threshold depending on the type of indication you're using for the tadalafil. So BPH versus erectile dysfunction versus pulmonary hypertension, they all have different dose thresholds. And corticosteroids, I'll say this is the most underestimated drug interactions because oftentimes we think a lot of these corticosteroids that are inhaled or intranasal spray are very minimal since they're not systemic absorption. But in fact, even though they are to be used inhalation or intranasal, they can still cause significant toxicities, including the Cushing syndrome and adrenal insufficiency. So it is contraindicated to be used with the budesonide, fluticasone, and mometasone. They are contraindicated to be used with protease inhibitor. But one exception is the beclomethasone, which does not interact with the protease inhibitors. So you may be able to convert those patients to beclomethasone inhalations. Versus patients taking betamethasone or budesonide systemic administration, unfortunately, it is strictly contraindicated to be used due to the significant risk of Cushing syndrome and adrenal insufficiency. And for beta blockers, for bisoprolol, carvedilol, and metoprolol, propranolol, make sure to reduce their dose based on their response, or you can simply consider switching to a non-3A4 substrate-based beta blockers. So those include atenolol, labetalol, and nadolol. And I want to highlight here for the direct oral anticoagulants, for apixaban, if you're make sure to reduce their dose by 50% if the patient is taking either 5 BID or 10 BID for either AFib or DVT. But some patients will be on a 2.5 BID for AFib dosing, but in that case, 2.5 BID is the lowest dose possible for apixaban. Therefore, you cannot achieve 50% reduction. So in that case, it is contraindicated. Versus we don't really use edoxaban a lot, but it is available. So if you end up having a patient with edoxaban, make sure to limit their dose to 30 milligram per day. But for rivaroxaban, due to their prolonged duration of activity, they are contraindicated to be used with all type of protease inhibitors. So I talked about a lot of different interacting medications. So the bottom line here is the 2D6 and 3A4 inhibitions from the protease inhibitors and their boosters is going to increase the serum concentrations of the 2D6 and 3A4 substrates, which can lead to significant unintended toxicities. So our next question is actually the last question of the day. So we have Mr. GJ, who is currently on Gemvoya. So it has elvitegravir, cobicistat, emtricitabine, and TAF, with undetectable viral load over 3 years. And today, the patient's PCP is reaching out to you about potential drug interaction with his Gemvoya because the patient is about to be started on a corticosteroid maintenance inhaler for asthma. So which of the following response is the most appropriate? I hear C. Yep. So, yeah, C for correct. So make sure to advise the PCP to use a different, alternate inhaler. So, beclomethasone is appropriate inhaled corticosteroids. And the purpose of this question was actually to highlight that the drug interactions with boosters also applies to other ART components that requires a booster. So within the VA, we use Gemvoya a lot because it has a cobicistat component that causes the drug interactions. Make sure to fully assess their full drug interactions. And I just want to include here for certain miscellaneous agents. So for miraviroc, which are 3A4 and PGP substrates. So make sure to avoid taking them with a potent 3A4 and PGP inhibitors and inducers. Versus lenacapavir, they serve as a moderate 3A4 inhibitors, and they themselves are also 3A4 substrate. So make sure to avoid using lenacapavir with other anticonvulsants, rifamycins, and protease inhibitors with a booster. So we talked about a lot of different drug interactions involving with ART components. So I want to provide some take-home points for you guys. So there are multiple consequences of unmanaged drug interactions with ARTs. So they include the increased ART toxicity or decreased efficacy. And it can also cause increased co-administered medication toxicity. It was a typo here, but it can also cause a decreased co-administered medication medication efficacy. And as a pharmacist, I'm going to tell you there are a lot of resources available for you to use on a daily basis. The first one is the drug package insert, which identifies the affected metabolizing enzymes. So, whether it's a 3A4 or 2A6. And it also lists the interacting drug classes and the names based on the conducted trials or based on the clinical practice. But they are not all inclusive. And there's the ART drug interaction management guideline, which was developed by the clinical info HIV.gov. And it quantifies the effect on the ART and the interacting medication drug concentrations. And they're categorized by the ART components. But as a pharmacist, the one that I use the most is the online drug interaction checker. So we have Micromedics up to date that you get free subscription within the VA. And there's a Liverpool HIV drug interaction checker, which I use the most because it identifies not only the severity of the interactions, but it also gives you the suggested mitigation plan if there is one. So some of the clinical pearls I want to share with you is first to understand different mechanisms of drug interactions that changes the pharmacokinetic properties. So those include the absorptions, metabolism, and excretion. And to be able to recognize common drug interactions by the ART components and other common CYP inducers and inhibitors, such as anticonvulsants and rifamycins and certain non-nucleoside transcriptase inhibitors, and be able to assess for presence of significant drug interactions and be able to formulate mitigation strategies by using one of the available online resources. And lastly, and the most, is make sure to counsel your patients about the drug interaction mitigation plan and be able to communicate with other providers that manage other interacting medications. So for example, if you're not the one managing their bupropion interactions, make sure to let the psychiatrist know about the existing interactions with the bupropion so they can take appropriate action on whether to increase or decrease their bupropion dose if necessary. So that's all I have for you all today. Does anyone have any questions?